Dr. Daisy Upal. I'm the founding radiologist at Charter Radiology. Over the last 25 years, I've had the privilege of interpreting breast MRI on hundreds of women. Over these series of webinars on breast cancer, I hope to share the imaging characteristics of breast cancer on breast MRI and to show you the value of breast MRI in evaluation, diagnosis, and treatment of breast cancer. This is a little bit about myself. I went to college at SUNY Albany. I subsequently went to medical school at Albany Medical College, and I did my internship and radiology residency at Albany Medical Center. I'm fellowship trained at Johns Hopkins Hospital and board certified radiologist. My specialty is cross-sectional imaging. I have been doing breast MRI for 25 years. I'm going to go over the indications and share a few cases with you. I have several hundred cases that I hope to share with you in the following subsequent webinars. We're going to go over the indications for breast MRI. Women with higher than average risk for breast cancer should undergo an annual breast MRI. Women with syndromes such as Lynch syndrome, Li-Fraumeni syndrome are at a higher risk for breast cancer and should have an annual breast MRI. Women with calculated risk of 20% or more on Gale model should have an annual breast MRI. Patients with a personal history of breast cancer and a strong family history of breast cancer. Women with a first-degree relative. And what does that mean? That means if you have a sister, a mother, or a grandmother who had breast cancer, you are at an increased risk for breast cancer, and you must have an annual breast MRI. Certain gene mutations patients with these gene mutations are at an increased risk for breast cancer. For example, if you have ataxia telangiectasia, the ATM gene mutation, patients with this mutation are at an increased risk, almost double the risk of an average person. Women with T greater than G mutation have a 50% chance of developing breast cancer over their lifetime and must undergo an annual breast MRI. Patients with Li-Fraumeni syndrome associated with TP53 mutation are at an increased risk. Patients with Cowden syndrome linked to P10 gene are at increased risk for developing breast cancer over their lifetime. Patients who've had a previous biopsy of the breast and have been found to have atypical ductal hyperplasia and lobular carcinoma in situ are at an increased risk for developing breast cancer and must undergo an annual breast MRI. So let's talk about the high-risk screening. Women with the genetic mutations are at an increased risk if they have these following mutations: BRCA1, BRCA2, PALB-B2, TP53, P10, CHEK2, CDH1, ATM, and STK11 genetic mutation are at an increased risk for developing breast carcinoma, and we recommend that they undergo an annual breast MRI. Guidelines for managing these high-risk patients are that they should start having an annual breast MRI starting at the age of 25, and then when they are 30, then you add screening mammography along with an annual breast MRI. Risk factors for absolute indications for screening breast MRI are patients who have a BRCA1 mutation or a first-degree relative of a person with BRCA mutation. Women who have had chest radiation for lymphoma are at an increased risk for developing breast cancer and must undergo an annual breast MRI. Intermediate risk for breast cancer. American Cancer Society guidelines consider women to be at an intermediate risk between 15 to 20% if they have a personal history of breast cancer, if they have dense breasts on mammography, history of high-risk lesions at biopsy such as atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. These are considered intermediate risk for breast cancer. It is recommended that they also undergo annual breast MRI. How do you calculate your breast cancer risk? It's a fairly simple tool. You can Google this, https breastcancerrisktool.cancer.gov. I was able to calculate my own cancer risk by utilizing this risk calculator and learning about the Gale model of breast cancer risk assessment. Mine came out to be pretty low, between 1% to 2%, but women whose risk is 15 to 20%, it is highly recommended that they undergo a annual breast MRI. So let's talk about how is breast MRI performed. Here at Charter Radiology, we have put together a great program for breast cancer screening. We have invested in the best MRI machines. We currently use only 3 Tesla Siemens MRI, and we have invested in the Sentinel coil, which is, I believe, is the gold standard for performing breast MRI. So both breasts are imaged simultaneously, and images of both breasts are performed in the axial plane. We first perform an axial T1 non-fat saturated image, which I believe is kind of like the lay of the land, gives you the same kind of view as a mammogram. Then we perform axial inversion recovery, followed by axial T1 fat saturated pre-contrast, and then dynamic post-contrast images obtained over 8 minutes. Contrast is injected intravenously in the arm, and then we obtain 3D reconstructed images and subtraction images. So I believe that at Charter Radiology, we only perform contrast-enhanced images. Contrast-enhanced images are superior for detection of breast cancer. Subtraction images are very key, and I believe that the reason we picked Siemens MRI because it offers superior and very homogeneous fat suppression, and I will share several cases with you, and you will be able to evaluate the image quality. So this is what our MRI machine looks like. This is the Siemens 3 Tesla Vita MRI. It has the highest gradients and the highest resolution, and we utilize the Sentinel breast coil. This is the 16-channel Sentinel breast coil. The patient lies prone on their stomach, and each breast goes into these cup holders. The patient's head lies within this head and neck holder, and the patient's face faces outwards. So it is basically what we say is feet first and prone, and the patient's head lies outside the bore of the magnet. So this is a fairly comfortable position. We offer the patient headphones as well as earplugs, and they can listen to the music while they're having this examination. Since the magnet is of very high gradients and it is a advanced 3 Tesla MRI, the examination is very fast and only takes approximately 15 minutes. So here is a patient lying prone on their stomach. Their head is outside the magnet, as you can see, and the arms must be by the head. This really helps in evaluating the breast tissue in the axilla. I prefer that either a radiologist or a woman technologist trained in positioning the breast patient is very important. The breast axilla tissue must be pulled into the breast cup holder, and there is very mild compression placed on the breast. The nipple must point downwards. This breast positioning is very important so that you don't get any clumped tissue, and the breast examination is performed accurately so that there are no false lesions identified. So it is vital. I take the care to train my technologist personally, walk into the MRI machine quite frequently, and I position so many of the breast patients myself. But I think training a technologist to position a breast patient is very important for the evaluation of breast MRI and breast cancer. In our MRI machine, the examination only takes about 15 minutes, as I said, and it takes approximately 15 minutes to position a patient correctly. So at Charter Radiology, we've really invested in the best of technology, and that, of course, means that we also use the best contrast agent. We have chosen Gatavist for utilizing. Actually, we use Gatavist for all studies, but for breast MRI patients, we use Gatavist because we believe that it is the only contrast agent that was approved for the evaluation of breast MRI and also helps in superior diagnosis of malignant breast cancer. Several studies have been done utilizing this contrast agent that shows that it is superior in the evaluation of malignant breast cancer. These studies, these brochures have been taken from the Bayer, the maker of this contrast agent, and these studies are listed here to show you that this contrast agent really is superior in the evaluation of breast cancer. And as I also indicated, that I believe at Charter, we believe that contrast-enhanced images are far superior for the detection of cancer, and therefore we only perform contrast-enhanced imaging at Charter. It is one of the safest agents. I share this data with my patients who have concerns about gadolinium contrast, and I show them that this Gatavist contrast is very safe, and here is their safety in clinical trials. And very few patients complain of a mild headache, which can be relieved by taking Advil or any of the other headache relieving agents. And very few patients even have nausea or any other symptoms. Most patients just complain of a mild headache. So breast MRI for screening. American Cancer Society and American College of Radiology recommend screening breast MRI in high-risk and intermediate risk patients starting at the age of 25. Asymptomatic patients and average risk patients, ACR and American Cancer Society do not recommend screening breast MRI for non-symptomatic or patients with average risk. In average or low risk patients, breast MRI is only utilized as an adjunct to screening mammography. So I want to talk about BIRADS lexicon and what is the BIRADS lexicon. So this is utilized on the radiology reports, and this is a way of communicating with the clinical team so that everybody is on the same page. Everybody knows what the radiologist is communicating, and this has been categorized into 6 categories. Category 0 means that this is a breast MRI which needs additional imaging or prior exams or correlation or biopsy. So category 0 is just like in mammography, means that additional imaging is needed. Category 1 means that it's negative. This is a normal breast MRI and no further workup is needed. Category 2, BIRADS 2, is a benign lesion. And for example, a breast cyst will fall into the benign category and no further workup is needed. So that is a communication to the breast surgeon, to the oncologist, and the primary care physician, or whoever the provider is that is taking care, that this is a benign lesion and no further workup is needed. Category 3 is the same, that this is a probably benign lesion, and the radiologist may offer a short-term follow-up, and that falls in this kind of category. When we say it's category 4, we're communicating to the clinical team that this is a suspicious lesion and needs a further workup. On breast MRI, it's actually broken into 3 other subcategories. 4A, which kind of indicates that this is low suspicion for malignancy. For example, a fibroadenoma would be in the category 4A. 4B means that this is a moderate suspicion for malignancy, and therefore we are recommending biopsy. Same thing on category 4C. That means this is the highest suspicion for malignancy. We are communicating to the provider and to the breast team that this is very suspicious for malignancy, and therefore we recommend a biopsy. Category 5 means that we are extremely suspicious that this is a breast cancer, and therefore the patient must undergo a breast biopsy. Category 6 is used for when it's already a biopsy-proven malignancy. So I want to go over what a normal breast MRI looks like. This is axial T1 weighted sequence, and this white is a predominantly fatty replaced breast. This is all the white areas are all the fat within the breast. And the darker area is the fibroglandular tissue, within the breast. This is the ribs, and this is the patient's heart. The next sequence I want to talk about is the axial inversion recovery. As you can see, the images are of extreme high resolution. The fat is dark on the axial inversion recovery sequence. The fibroglandular tissue is slightly hyperintense or bright. Next, we perform a pre-contrast. These are pre-contrast images. As you can see, there is no contrast. The heart is not lit up. And the post-contrast and subtraction images are really high resolution here, demonstrating that contrast has been given. And how can we tell that there is contrast? There is contrast within the heart, and none of the fibroglandular tissue enhances, and there is no cancer. If it was bright, it would be very hyperintense or very bright, and that is very highly suspicious for malignancy. But in this patient, there is no background enhancement. There is absolutely no enhancement and no enhancing mass seen, and this is a normal breast MRI. We're going to go over a lot of cases, starting with this one. Case 1, this is a 47-year-old female with an abnormal mammogram performed, and a left breast mass was seen on the mammogram. The mammogram was read as BIRADS 4, which is highly suspicious for malignancy. We were asked to perform a breast MRI for the evaluation of this mass. So these are the T1 weighted non-FAT-SAT sequences. You can see that this is a very dense breast. There is very minimal fat, and there's a lot of fibroglandular tissue. This is a very dense breast. This is the right breast. This is the left breast. And within this left breast, on this non-contrast sequence, you can see that there is a mass which is hypointense. On the T2 weighted images, you can see there is very dense right breast, and there is a lobulated cystic mass within the left breast. This is actually bright. It has some internal septations. Contrast was then given, and you can see that the normal fibroglandular tissue also picks up contrast and enhances. And this mass in the left breast demonstrates no enhancement. The normal fibroglandular tissue does demonstrate some enhancement in the background. There is contrast in the heart, so you know that the patient did receive contrast. But this lesion itself, the left breast lesion, demonstrates no enhancement. These are the subtraction images, and there is no enhancement of this mass. We are very comfortable in saying that this is a benign lesion. This is a cyst, and it demonstrates no enhancement. This is a MIPT image. We do perform MIPT images, and I do look at them, but I don't use them really for diagnosis. This is a MIPT image to kind of give the same view as a mammogram. So breast MRI confirmed that this benign lobulated lesion is a simple cyst, and therefore a benign lesion, and is BIRADS 2. Surgical resection was performed, and pathology confirms that this was a cyst. The second case I'm going to show you is of a patient with an increased risk for breast cancer. This is a 68-year-old woman with a very strong family history of breast cancer. Her mother had breast cancer, her maternal grandmother, paternal grandmother, maternal aunt all had breast cancer. So she had a mammogram, annual mammogram, which demonstrated an asymmetrical density in the left breast. Her primary care physician sent her to us for a breast MRI. So this is the axial T1 weighted lesion again, T1 sequence. This is predominantly fat, and there are scattered fibroglandular tissues in both breasts. In the right, this is the right breast, this is the left breast, this is the rib cage. This is the axial inversion recovery, or T2 fat saturated sequence. This shows that the fat is dark, and this is the normal fibroglandular tissue. This is the T1 pre-contrast images. So when we give contrast, you can see that a breast mass lights up. This is the reason why I strongly believe in contrast-enhanced imaging for breast cancer. This patient was sent to a breast surgeon, and she underwent a biopsy. which confirmed that this is invasive, moderately differentiated ductal carcinoma. ACR and Charter Radiology strongly recommend screening of women with strong family history of breast cancer with breast MRI on an annual basis. The third case is a 44-year-old female with dense breasts who has been having annual mammograms since the age of 40. Patient presented with a lump. A mammogram was performed 1 month ago, which was negative. An ultrasound demonstrated a hypoechoic mass. Biopsy was performed, which demonstrated ductal carcinoma with lobular features. Breast MRI was performed for staging. Again, this is a axial T1 sequence, and this is prior to giving contrast. So these are pre-contrast sequences. This is the fat within the breast, and this is the fibroglandular tissue. You can already see that this is fairly dense breasts with moderate fibroglandular tissue. Here is the T2 weighted sequences, and it shows these small cysts and pretty dense fibroglandular tissue. When we give contrast, there is this enhancing mass in the right breast. Here's contrast in the heart, and this was sent again to the breast surgeon for biopsy. And actually 2 other smaller additional lesions have been detected on the breast MRI contrast-enhanced images. Biopsy of this mass actually demonstrated that this additional lesions also demonstrated that this was breast cancer. This was an invasive ductal carcinoma with lobular features. Case 3, this is a woman who presents with a mass, and I think she had some discharge in her breast. This is a mass that you can see in the right breast. This is a lobulated septated cystic mass and extends into the right nipple. And this was an intraductal papilloma. So what is an intraductal papilloma? It is benign proliferative lesion of the mammary duct. It has an increased risk for developing a ductal carcinoma in situ, an invasive ductal carcinoma. Intraductal papillomas are of 2 types. They can be central or peripheral. This mass that I just showed you previously was a central intraductal papilloma. It is found in large subareolar ducts and causes spontaneous nipple discharge. This is an interesting case. This is a 36-year-old woman who had large breasts and underwent breast reduction and presents with a painful left breast with hard mass. She was treated first by the breast surgeon conservatively with antibiotics, but she had no decrease in symptoms, and she subsequently required breast drainage. So here is this right breast, and there is this left breast, and you can almost visualize that there is a mass, and this area extends up to the nipple. And also extends into her left pectoralis muscle, and there is surgical discharge from the left nipple. After enhancement, this mass really enhanced. So we knew that she had undergone breast reduction, so we knew that this is more of an abscess. This patient subsequently required surgical drainage and is doing much better now. Case 6. This is a 46-year-old female. She presented with back pain. MRI showed metastatic lesions in the thoracic and lumbar spine. A bone biopsy demonstrated that this was metastatic breast carcinoma. She had undergone a normal mammogram a few months ago. So here is her CT scan, which demonstrates metastatic lesions within the T10, L2 vertebral body and L5, and as well as L2 vertebral body. This is an image from her CT scan of the liver, which shows liver masses. So we did a breast MRI to see where the primary was, and we see that she has an enhancing mass in the left breast. She also has metastatic disease to the left ribs. Subsequently, a PET-CT was performed at Charter Radiology, which demonstrates multiple areas of metastases. I wanted to show you her recent PET-CT. She's actually doing very well, and a lot of these areas are in remission. Case 7, this is a 51-year-old woman who presents with a palpable mass in the left breast. It's biopsy-proven breast carcinoma. So there are several markers that the oncologists look for that helps them picking the right chemotherapy regimen for the patient. These markers are very important. They look for the hormone receptors. If the patient is hormone receptor positive, they also look for HER2 new markers, and this was the makeup of this breast cancer. This is the right breast again, and it shows, and you can already see that in the left breast, this patient has skin thickening, and there are these several masses in her left breast extending all the way in her axilla. There are several masses. This is a large mass. This is a second mass and a third mass extending up in the axilla. And when you give contrast, these masses light up like a light bulb in the left breast. And we actually did her PET scan, and these masses extend all along her breast, outside the breast, and in the chest wall itself. Case 8 is a 78-year-old female with palpable right breast mass. She underwent an ultrasound-guided biopsy, and it demonstrated to be a poorly differentiated ductal carcinoma. This is her right breast. This mass is so large, you can actually, these are, again, non-contrast axial T1 weighted images. You can see that this large mass demonstrates skin thickening and a fungating large mass extending outside the right breast. And here is this very large lobulated mass. There is intense angry edema within the right breast. There are central areas of necrosis, no masses in the contralateral breast. So surgeons will send for these cases for breast MRI because they help in the surgical evaluation and in preparation for breast surgery. And they also want to know if there is cancer in the contralateral breast. And that helps in the surgical planning, whether the patient will undergo unilateral mastectomy or bilateral mastectomy, and that's a conversation between the patient and the surgeon. And so here is that mass again. This is the pre-contrast images, and this is the post-contrast image, and you can see this very large mass fungating outside the right breast skin and also extending into the right nipple. There are several smaller satellite lesions within the right breast. Case 9 is a 53-year-old woman with a rapidly growing left breast mass who presents to us for MRI. And again, here is the pre-contrast axial T1 weighted images. The right breast is normal. This is the fat, and this is the fibrogranular tissue. This is a moderate fibrogranular heterogeneous breast parenchyma. Here is this very large lobulated mass that we can even see on the T1 non-contrast images. There is evidence of skin thickening, and these are the T2 pre-contrast images. This mass is still dark and heterogeneous on the T2 weighted sequences. After the administration of contrast, you can see this large enhancing mass with central areas of necrosis. This was a poorly differentiated ductal carcinoma. Next case is of a 68-year-old woman with invasive ductal carcinoma of the left breast. This is ER positive, PR negative, HER2 new positive with pathologically proven metastases to the left axillary lymph node. So here is this mass. This is again the right breast, axial T1 non-contrast images. You can see that there is a somewhat lobulated area, which is hypointense on the T1 weighted images. On the T2 weighted images, this is bright on T2, and you can already see that there are metastases in the left axilla or a second satellite lesion in the left axilla. After contrast, this mass rapidly enhances. This is a spiculated, non-homogeneous mass. This does not appear to be benign. This is a malignant, or what we say is carcinoma. There is a second satellite lesion over here, and I can see another lymph node or another third satellite lesion here. This was a poorly differentiated ductal carcinoma. Case 11 is a 68-year-old woman with biopsy-proven invasive ductal carcinoma, moderate to poorly differentiated. Here are the markers of the tumor. As you can see that this is again a dense, very dense breast. Here is the fat in the breast parenchyma, but predominantly this has a lot of fibroglandular tissue. This is a very dense breast. Carcinomas on mammogram can easily hide in the dense breasts and are difficult to read. So here is this mass, enhancing mass in the right axilla. You can see that this is a biopsy defect, and that shows up as a susceptibility artifact on the breast MRI. This is a poorly differentiated ductal carcinoma. Case 12, this is a 57-year-old woman with ER positive, PR positive, HER2 negative, K167, 5-10%. This is an invasive mucinous carcinoma. On the T1 weighted images, this is pre-contrast. You can see that there is a focal mass here. This is dark or hypointense on the T1 weighted images. On the T2 weighted images, this is actually a bright and it's ill-defined. This may appear to be a cyst, but that's why we go to the contrast-enhanced images. On the contrast-enhanced images, you can see that this is a very not focal enhancement. It is somewhat irregular, this mass. And this, as we know, is biopsy-proven carcinoma. Case 13 is a 68-year-old woman with ER positive, PR positive, HER2 negative, K167 negative, invasive lobular carcinoma in situ. We know that lobular carcinoma in situ is the hardest to diagnose, both on mammography as well as on MRI. Here is the right breast. And if you look at the left breast, there is evidence of skin thickening. The nipple is retracted. And on the T1 weighted images, this is dark and hypointense. And on the T2 weighted images, it is somewhat bright. When we give contrast, you can see how much the enhancement is very rim-like, and it has a lot of central necrosis. The nipple is retracted, and this was lobular carcinoma in situ. Case 14 is of an 82-year-old woman with ER positive, PR negative, HER2 negative invasive lobular carcinoma. You can very much appreciate the difference in size of the two breasts. The right breast is smaller than the left breast. The patient has breast implants in place. These are the implants. And on the T1 weighted images, if you look at the breast parenchyma, this is hyperintense. It has almost a mass-like appearance. As compared to the left breast, there is no fibroglandular tissue in the retroareolar region. This is the retroareolar region. Already you can appreciate the difference that between the two breasts. And when we give contrast, this mass enhances after we give contrast, and this was lobular carcinoma. Case 15, I wanted to show you that this is a mass. This is again T1 weighted images, and you can appreciate that there is a mass here, and this is hypointense both on T1 and T2 weighted images. This mass enhances after the administration of contrast, and this is a well-differentiated invasive ductal carcinoma. Case 16 is a 53-year-old woman presents with a rapidly growing mass in the left breast. Last mammogram was performed 6 years ago. And here is the T1 weighted images. The right breast appears normal. It's a very fatty replaced breast, and this is the fibroglandular tissue. And within the left breast, you appreciate a very large lobulated mass. This is dark on T1, and this is heterogeneous on the T2 weighted images. We are doing this breast MRI not only for surgical planning, we're also doing this breast MRI to see if there is any cancer within the contralateral breast. So this is the pre-contrast images, and the post-contrast images demonstrate that this is a very large necrotic enhancing masses. This is centrally demonstrates no enhancement. There is very heterogeneous rim enhancement. We know that this is carcinoma. There is already axillary lymph nodes or satellite lesions, and there is no cancer within the contralateral breast. Case 16 is a pathologically proven invasive ductal carcinoma, negative for ER and PR. Ki-67 index is 80 to 90%. This is almost a inflammatory breast cancer. So if you look at this right and the left breast, you can appreciate that there is a significant size difference between the two breasts. The right breast is smaller than the left breast. There is marked skin thickening, which is appreciated on this non-contrast image. And there appears to be a very mass-like area within the retroareolar region. The nipple is retracted as compared to the left breast. This is actually inflammatory breast cancer. Post-contrast, you can see that there is intense enhancement in this region in the right breast, and there is skin thickening. This was inflammatory breast cancer. You can also appreciate these enhancing satellite lesions and enhancing lymph nodes in the right axilla. Case 18 is a 66-year-old man who presents with right breast mass. I threw this case in because I want to bring attention to the fact that even men get breast carcinoma, and I wanted to bring attention to that. We understand that predominantly breast carcinoma is a woman's disease, but there's men who present with right breast mass as well, and breast cancer does occur to a smaller number within men. So this is a man's breast. As you can see, it is much smaller than a woman's breast. This is a T1 pre-contrast image, and this is a post-contrast image. There is this retroareolar region which demonstrated no enhancement after the administration of contrast. So there is a retroareolar mass in the right breast. This was actually biopsy proven. These are pre-contrast images. And as I showed you on the post-contrast images that there was no enhancement, this was actually gynecomastia. I also wanted to just touch upon, over this next series, I will show a lot more cases, but I wanted to talk about breast implants and the evaluation of breast implants as well. This is a 78-year-old woman with silicone breast implants. And here are the implants. And you can see in this woman, her implant is fairly irregular here. It is the implant should be, these are the internal septations between which are normal within the right breast implant. But if you look at the left breast implant, it is very irregular, and you see the silicone leaking out into the axilla and along the chest wall and along the rib cage. So we frequently do breast or implant rupture and the evaluation of implants. And as you can see, this on the MIPT images, this is very, very helpful. You can see that the superior aspect of this implant is not intact, and the silicone is leaking out along the breast wall. Here are several silicone deposits along the left chest wall. And here's another image of the same patient, and you can see it along the rib cage. There are the silicone implants outside of the implant, and so the patient needs a revision of the implant. This is a 60-year-old woman with right axillary breast mass. The breast MRI is performed to characterize this mass and to evaluate the extent of the cancer. So here, this is a moderately dense breast, as you can see by now. This is axial T1 weighted images. This is the fibroglandular tissue, and this is the fat within the breast. Again, this is the rib cage and the pectoralis muscle, and you see this mass within the right axilla. And this is the T2 weighted images. This is non-contrast still, and you can see this mass is heterogeneous in signal. And when we give contrast, this mass enhances. This is the surgical defect, the biopsy defect, and this was invasive carcinoma. And in this, only the mass was only localized to the right breast. As you can see on the left breast, there is no enhancing masses, so there is no mass within the contralateral breast. And so then the surgeon and the patient can have a conversation as to how they are going to go surgical management, whether they are going to have a unilateral mastectomy or bilateral mastectomy. Case 21 is a biopsy-proven invasive ductal carcinoma. This is an ER/PR negative, HER2 negative, score of 0 plus, and Ki 95%. As I say that these markers are very important for the oncologist to pick the regimen of the chemotherapy agents. right breast mass, biopsy-proven invasive ductal carcinoma, moderately differentiated. The breast MRI is again performed for surgical planning and to evaluate for breast carcinoma in the contralateral breast. So here's the right breast. These are contrast-enhanced images. As you can see, this is a very brightly enhancing mass within the right breast. This is the biopsy-proven. And within the left breast, there is this small foci of enhancing mass. And you know that this is highly suspicious for metastatic or contralateral breast carcinoma, which changes the surgical planning of this patient. And these are the MIPT images. The MIPT images, as I said, I look at them and they really are quite impressive, but I do not use them solely for diagnosis. And as you can see, how this carcinoma is being fed by these vessels, so it's very impressive. The patient did undergo PET-CT at Charter Radiology, and here is that enhancing mass in the right breast, which picks up the radiotracer. So I did want to show that since we have a PET-CT at Charter, well, very high, 128 slice CT, PET-CT at Charter Radiology, which we utilize for these patients. So I wanted to share. And over the next several webinar series, I will be showing a lot more PET-CTs along with the breast MRI. Case 23 is a woman with prior history of breast cancer with prior lumpectomy. She has a strong family history of breast cancer. Patient's mother had breast cancer, were asked to evaluate for recurrent carcinoma. Breast MRI clearly differentiated between scar and carcinoma. So the reason I picked this case is because these women's mammograms are very difficult to read since they've had prior lumpectomy. The breast is deformed, and these can be quite difficult. And so breast MRI is very valuable in their care because breast MRI can clearly differentiate between recurrent carcinoma and scar. So scar does not enhance on breast MRI and is really, really helpful in diagnosis. So here is a patient, and this is the breast MRI. As you can see, the right breast is much smaller than the left breast. Here is the spiculated area, and you want to wonder if this is recurrent carcinoma. And this is also the site where the patient had the prior lumpectomy. So here it is on the T2 non-contrast images. It is very spiculated. And again, this could be very suspicious for recurrent or new carcinoma. And after we give contrast, this area you can see on the post-contrast subtraction images, this, as I've said, I really do appreciate our technology that we have put together because look at the high resolution images. This area demonstrates no enhancement. So as a breast MRI radiologist, I am very comfortable in saying that this represents a scar and does not represent recurrent carcinoma. Both me and my patient are very happy with the diagnosis. Case 24 is a 51-year-old female. She presents with a palpable lump. We did an ultrasound and it shows this very spiculated hypoechoic mass on ultrasound. It is very ill-defined. There is shadowing and this is very suspicious. We performed a breast MRI on this patient. This patient, as you can see, this is scattered fibroglandular tissue. This is the right breast again. This is the left breast. And on the non-contrast enhanced images itself, you can appreciate that there is a mass which is hypointense in the left outer breast. Here it is on the pre-contrast T2 weighted images. So after we give contrast, there is intense enhancement of this mass. And not only is this mass enhancing, their patient has two other enhancing masses in the left breast, which changes the surgical management of this patient. There was no cancer in the right breast. There was no mass found in the right breast. There were at least 3 masses seen in the left breast. This patient subsequently underwent mastectomy and is doing really well. Case 24 is invasive ductal carcinoma. It's estrogen and progesterone positive and HER2 negative. So 69-year-old female, she presents with a 29.4% lifetime risk for breast cancer and has a strong family history of breast cancer. Her mother, her sister, and maternal aunt had breast cancer. She presents, again, this is a T1 weighted non-contrast enhanced images, and I'm not sure, but this area seems much more hypointense and mass-like. These are non-contrast enhanced images, and after we give contrast, you can see a very intense enhancing mass. These are the subtraction images, which really leaves no doubt in our head that this is a enhancing cancer. So if we can go back and look at the non-contrast enhanced images, once again, here was this non-enhancing mass like area, which was highly suspicious. And once you give contrast, this mass enhances avidly. And this is a pathologically proven invasive moderate grade ductal carcinoma. This is a nice case. Patient underwent a lumpectomy and has been having a annual breast MRI at Charter Radiology since her surgery. We've been following her for 10 plus years and she has been doing really well. Case 25 is a post-lumpectomy patient. I also wanted to show that, again, these masses, these cases are difficult to read on mammography since post-lumpectomy, the breast gets deformed and their mammograms can be quite difficult to read. These patients on a breast MRI, this is the right breast again, and this is the left breast. As you can see that the left breast is deformed and has this hypointense area. The left breast is smaller than the right breast. And post-contrast, you can see that there is no enhancement within this breast. So it is very definitive for the evaluation of residual or recurrent carcinoma, and breast MRI is very, very helpful in patients who've had a prior history. If they undergo a breast MRI every year, they feel very comfortable with the answer. And I think breast MRI is very valuable in their care. This is a MIPT image again. This is, as I said, I look at them, but I really don't use them for diagnostic purpose. Case 26 is a 73-year-old woman who had an abnormal mammogram. Biopsy demonstrated invasive, poorly differentiated carcinoma, triple negative carcinoma. Breast MRI is ordered for extent and characterization of carcinoma. In the subsequent webinars, I will talk about triple negative carcinomas. These can be quite challenging. Here is this right breast with a hypointense foci, and here is the left breast. This is pre-contrast images again, and post-contrast you can see that this mass enhances and there are several lymph nodes in the right axilla. And here is the post-contrast images. This was triple negative breast carcinoma. Here is the MIPT images. These are quite impressive. You can see the lymph nodes in the right breast. Case 27 is a 67-year-old presents with an abnormal mammogram. Patient had routine mammograms prior to the abnormal mammogram, which were all negative. Subsequent ultrasound performed, which demonstrated a well-circumscribed mass at 12 o'clock. Subsequent biopsy demonstrates invasive ductal carcinoma. Breast MRI was performed for staging. So again, this is the T1 non-fat sat sequence. You can see that there is a hypointense mass. I think this is one of our first patients ever performed at Charter Radiology. And the T1 enhanced image demonstrates there is no minimal background glandular enhancement pattern, but there is an intensely enhancing mass, which was the carcinoma. So Charter Radiology is a radiologist owned and operated. We have no financial commitments from anyone, no grants. There were several citations that I used, I used these papers for confirming my own knowledge. Charter Radiology has 3 centers. The 2 centers in Howard County have the Sentinel Breast Coil where we perform the breast MRI. These are our locations. You can call 443, text us or email and schedule your breast MRI at Charter Radiology. Thank you for listening. I greatly appreciate you.